All right, well, welcome to webinar number 5 of the Pearls Trainer Training. I will be your host. I am Caitlin Mayat. I think you all know me at this point. Leslie and Mark are hosting another webinar for one of our research projects, so they weren't able to join us today. But we are covering implementation, evaluation, and some of the things that you'll need to keep in mind for in-person training. And this is a lot of what I do to support Leslie. So you're in pretty good hands. And if you have additional questions that for some reason I'm not able to answer, you can send her an email. Mark Snowden. Many of you may know him from some of the TA calls, and he may have done the clinical supervision and suicide protocol pieces of your respective trainings. So that's what he'll be covering next week for webinar number 6. So you get to meet him then, and you can ask him questions too if it's something I'm not able to answer today. So today our objectives, as you learn how to train others to deliver pearls, you're going to learn how to discuss with them implementing pearls after their training, how they're going to do the screening, recruitment, staffing, technical assistance, and fidelity monitoring. You're going to talk to them about how to evaluate pearls, which includes the data management and one model for ongoing evaluation, REAIM. And we'll talk a little bit at the end about how you are going to plan for a potential pearls training. So Bob Pike is a leader in this field, and he has some tips to keep in mind for adult learning. So as you are teaching others to deliver pearls, don't talk at them, involve them as much as possible. Encourage positive group dynamics. You can move people around, especially for role plays. Don't let them just be with their buddy the whole time. You may have a small training where everybody's from one organization and they may know each other, or you could have, like Leslie and I went to Fort Worth a couple of years ago and had a huge training with about 40 people from all different organizations. And there were some interesting group dynamics there. So shaking it up, moving them out of their comfort zone is pretty helpful. But making sure also that everybody feels comfortable to share their experiences, because they may be coming from a lot of different backgrounds or have different roles at their organizations or potential roles with pearls. So giving everybody a chance to speak is pretty important. Let them discover the data for themselves. The training involves a lot of information. For some people, it'll click right away and make total sense. For others, it's a totally new approach and philosophy, and it can just take some real getting used to. And as you all know, it's really a learn by doing sort of program. So just giving them time and opportunities to mull over it, and encouraging them that even towards the end of the training, if they're feeling like, I don't know about this, redirect them to the resources that are available. We have lots of guides to help them walk through the different pieces of the program. Literally, they can use it like a script to help them get into the habit of going through these different steps with their clients. You can have them keep an action list or ideal list. We usually call that a parking lot. When we've done in-person trainings, we've had, one of those giant Post-it sticky boards just listed with parking lot. And if somebody comes up with a question and it's something that you haven't gotten to yet, or you want to go back to, or it's not a question that makes sense to answer right then and there, put it on the parking lot. And there's lots of opportunities to go back to that and re-engage people. And always turning the questions around back to the audience, like, okay, that's a great question. How would you answer that? And let them work with each other as much as possible. If you're doing a group training, it's a little bit different if it's just one person from your own organization, but really giving everybody a chance to practice discussing each of the parts of the program is it's important for helping them internalize the different steps. And try and make it as fun as possible. We try to do that as much as possible, but there is just a lot of information. And so like I'm doing now, a lot of it is telling them about the different pieces and talking at them. Let's see. So change the pace as much as possible. So you can get like 20 minutes of attention out of people max for discussing some of the different topics. Break it up into practice sessions and role plays, ask questions of them, take breaks, try and read the audience as much as possible. You'll see lots of fidgeters. You'll always have somebody who's very engaged and very ready to keep going, but most people need a stretch break at a minimum. When we do the in-person trainings, we don't go more than an hour without like a potty break. 5 minutes is all it takes, but just wiggling around. And we try to have them come back and regurgitate something to us, either in a role play or similar to the teach back that we'll do at the end of the session. And your job as their trainer is the same as their job as the coach, to be their cheerleader and help them feel confident. Because like I said, some of these folks, these are new skills for them, and they may not feel very confident with their own abilities or their ability to bring that to an older adult in their community. And so find ways and opportunities for them to feel impressed with themselves and confident about delivering the program. Any opportunities for them to share their own experiences with their organization or other volunteer work that they've done. That's great for them to feel confident that they're applying these concepts and ideas that you're discussing with them to their experiences and helping them visualize them doing it in the field. It's also great for others in the training to be able to hear those experiences and make those connections mentally with their own experiences. We try to offer the training in lots of different ways. So, talking to them, watching videos, watching demonstrations, making them do demonstrations, working on the elevator speeches, filling out the forms, all different ways for different people to learn the material, because everybody learns differently. And so making sure that you are touching each of those different learning styles for the different people in at least some way. And then once they get it in a way that makes sense for them, then they'll be able to connect the dots for the other pieces. And then bring passion to it. You have all been doing pearls and you have great examples to bring to it. The funnier, the better, the more engaging. But not just the wins, right? Sharing your examples of defeats or situations that didn't work out great. That's super helpful for them to hear that, especially if they're still having doubts about some of their skills. Giving an example of a time that you screwed up or it didn't resonate the way you thought it would with a client, that's going to be really helpful for them to feel like, okay, real people are delivering this program. I can do this. And helping them preemptively get over their anxieties about it. So today's teach back, I'm going to have you tell me 3 different ways that an agency can measure the Pearls program effectiveness, specifically using the PHQ-9. So we will discuss this, but keep in the back of your mind, we're looking for 3 ways that the PHQ-9 can really help the agency. And then the second one is going to be describing the REAIM framework. Right, so before I dive into implementation, anybody have any questions? I can't, hold on, let me put you in. There we go, now I can see you all. No, okay, stretch break. There you go. All right.
I got that joke. Stretch break.
Okay. Yep. All right, so these are the materials that I'm sure Leslie has discussed with you. Different training handouts, all the notes from the PH LearnLink website, the trainer manual, and of course, the implementation toolkit. Those are all available on the PH LearnLink site. You will continue to have access to all of those resources forever. That doesn't go away. And we are still working on making the rest, like the entire Pearls compendium of resources available on Google Drive. I mean, I think we're trying to find out when it doesn't work for people so we can give them access. But our goal is to make everything easily accessible for all of you to share with others at your organization or your clients, as like to get the things you need to work with your clients and anybody that you're training, of course. Right, so these are a lot of the areas that we have found tend to come up a lot during trainings, especially if you have teams of people from the same agency with people in different kinds of roles, like an administrator role in particular. So we will be discussing, you will be discussing depression screening, referral and recruitment, how to measure the outcomes and assess those, staffing needs for the organization, how to educate their agency at a larger level, if applicable, training and technical assistance needs, funding for Pearls, and figuring out if Pearls is a good fit for their organization. Really, that's question number one. We have had lots of people go through the training before they've considered all of these different pieces, and then they never end up implementing Pearls at their organization. So that's disheartening for us, and it's just sort of a waste of their time and energy and money. So really helping an organization figure these pieces out before they come to a training is ideal, because you want them coming to training when they're getting pretty close to ready to start a program at their organization. As you know, so much of the training is skills building. And so if they practice all these skills and they're like, yeah, okay, I can do this, and then they don't see anybody for 6 months because they weren't ready to roll, they're going to lose a lot of it. They're going to feel less confident, and it's not setting them up for optimal success. So helping them figure out if Pearls is a good fit for their org. This is thinking about, it's looking holistically at the organization, not just if it's a smaller group that's thinking about offering Pearls. And so if they are trying to sell this to higher ups in their organization, because they've heard about Pearls, they've seen it work at other orgs that they are partnered with, and they think it might really, really work. There's a lot of different ways that you can support them in coming at it to their supervisors or, administrative leaders. So helping them make a connection between Pearls and their organizational mission. So if the organization as a whole is concerned with overall health of people, that includes emotional health, and Pearls is addressing symptomatic depression. So it's definitely working towards maximizing that overall health, especially if they're serving lots of different people. It's always okay to have a group focusing on older adults. There's always more that we can do to support older adults in our community. And you can frame it as problem-solving treatment is really geared towards empowering patients to solve the issues. So that can be a really attractive piece to organizations that in general encourage their clients to direct their own recovery. Organizations may have already done evidence-based programs for other areas, not necessarily depression. And so if that's the case, they may have already set the groundwork for adopting a program like Pearls. And so having that information readily available, helping the supervisors see like, this isn't as big of a lift for us. We've already done this and it's been successful. Now let's do this again, but for depression with older adults. Let's see. Oh, another consideration is some organizations have different programs where they're seeing clients or just people in their community, but those programs, even if they're evidence-based programs, they might not be as long as Pearls. They might be shorter 6-week programs or something, enhanced fitness or enhanced wellness, chronic disease self-management program. I think those are all 6 to 12 weeks. Pearls can last for up to 6 months. I mean, that's average. It can last even longer depending on the client. So making sure that the organization has the ability to see clients for that length of time. That's something that I think not everybody has considered when they're used to the quicker turnaround programs where they may offer that a couple times a year. Pearls is it's longer, and you're going to have people at different phases of the program, which can be great if you have a full-time staff person to do that, but it can be a little more challenging, especially for smaller organizations. So just helping them think about all these different pieces. And then as far as depression screening and referral mechanisms, some bigger organizations, especially healthcare or mental health programs, they may already do universal depression screening, which is great. If it's an organization that doesn't, trying to help them think about getting to that universal depression screening, just in general, is going to be helpful. It's going to increase the pool of potential participants that could be referred from other programs or groups inside the organization. But it's also just a good way to get the temperature of how the older adults that are at their organization are doing. Does that make sense? Any questions there? Sorry, I just told you, like, don't just talk at people forever. And there's going to be a lot of me talking at you today. I'm sorry.
Talk away, talk away.
All right. All right. So you all know about depression screening options. We have typically chosen to go with the PHQ-2 and PHQ-9. You can also use the geriatric depression scale. I think the short form is pretty common. So if an organization is already using the GDS for universal screening or just when they need it for certain programs, that's fine. It doesn't matter. There's a couple other tools available out there. I'm not really sure what the CARE tool in Washington State is, but I know that an example is that there's a program in San Diego that was using, they were having all of their Meals on Wheels drivers administer the PHQ-2 when they go to deliver food. And so that was just helping them gauge potential referrals. And so I think they would send anybody who, lit up with the PHQ-2, they'd pass it on to the Pearls group, who would then do outreach and do the full PHQ-9 and start the screening process for potential clients. And that was great because Meals on Wheels was already seeing people who were in their homes, whether they're homebound or not, but there can be a lot of overlap between Meals on Wheels and Pearls in terms of the clients. So those are just some examples that you could share with people. Other ways that your organizations have, started the screening and engagement process, definitely share that. Try and get a sense from people at the training if they're doing any type of depression screening, what that is, and get them starting to think about ways that they can leverage existing systems at their organization and expanding to then make the connection to Pearls. Referral and recruitment. These are challenges that are really significant, as many of you know. Just because an organization builds a Pearls program does not mean that clients will flock to them. You need to consciously go over with the trainees different things that they can do to get this engagement going. So definitely start with appropriate materials and mediums. Maybe that's flyers. Maybe it's making special flyers. Like we've had groups who are specifically trying to target veterans to enroll in Pearls. And so those flyers had flags and eagles on them, something that would catch a veteran's eye and make them feel like, oh yeah, they might get me a little bit more. Not every community is going to respond to written materials necessarily. Here in Seattle, we have the International Drop-In Center. They are a Filipino community center, older adult and community center. And for them, it was connecting with the local Filipino language radio channel. And they had some advertisements to get people to engage. For that community, there's a lot of, oh, that's good. My power. Let me know if you lose me. There's a lot of suspicion and fear around any sort of paperwork. So finding other ways to reach the people that they're serving. And also, of course, they very much did conversations in person at the community center to try and drum up excitement about it. Make sure people understand that they need lots of different referral mechanisms, because they might have a really successful referral mechanism, but it might only be reaching one demographic or one group of older adults, where really their organization as a whole is reaching lots of different types of people. And so trying to broaden the horizons there. Always conducting presentations with other providers, whether that's internal to their organization, could be case managers or physicians or healthcare practitioners. It could be providers in their area, and giving a presentation to them about Pearls is a really important way for the providers to understand what Pearls does and does not offer, so that they can make informed and helpful referrals, not just, oh, this person is depressed, you should go to Pearls. It's like, well, okay, that didn't tell me anything other than I need to maybe screen them. Just because they are depressed doesn't mean that that Pearls is going to be a good fit for them. Hopefully, yes, but there's other factors to take into consideration. You all know this, but just reiterating this to trainees, especially new programs that are trying to get started. Go ahead and normalize recruitment rates, because those rates may not be nearly as big as clinic recruitment rates that they may be used to seeing in their organization, especially if it's a clinic setting. The scale is very different for CBOs, and it can take a lot longer to get recruitment rates up. If you think about like a new coach, if you can get a new coach enrolling like 1 to 2 people per week, by 6 months, they should have a pretty full caseload, and folks will start graduating, and they can then start outreaching and or starting the program with, if they have a waiting list. It sort of titrates the in-home visits, since they're not having to go to everybody's house. If they're at the end of the program, they can start doing screening and enrollment with new people. But just helping them have a realistic idea that things may be slow to start, and that's okay, that's normal. We already talked about cultivating community relationships with other agencies, clinics, going to health fairs, flyers and brochures, and having materials for providers, but also clients. There may be some different information that you want to share there. And then, of course, at your organization, at their organization, if they want to expand the eligibility criteria, they can talk to you, they can talk to whoever their clinical supervisor is going to be. They can talk to us if they have questions about it. But Pearls is really adaptable, and making it fit the needs of the communities they're trying to serve is important. Yes, Cynthia.
Sorry, Caitlin.
No, that's okay.
That last one, expand eligibility criteria.
Mhm.
What I have done is, our local Alzheimer's Association can no longer do, but if it were caseloads.
Mhm.
And so they are now referring people to me to work with family members and early onset,
Yeah.
or, the earlier stages, I should say,
Mhm.
prevention needs. Now, in Pearls last week, we were told, no, you cannot work with people who have dementia.
Well, that's where you're going to want to use the cognitive behavioral assessment, because it depends on the person. But yeah, anybody with significant cognitive impairment is not going to be able to follow the different steps needed.
Right. So
But if it's early onset and
well,
it's well controlled at this point.
It's not the early onset. I'm sorry, the earlier stage. So when I do the brief memory, I put a limit on it. If they get one or two wrong, then I have to work with their family. Now, if it's more than the one or two. Whereas one or two, we all make mistakes,
Yeah.
I mean, when we're retired, we don't know the day of the week anymore sometimes. And that's
Well, I have young kids and I still can't tell you the day of the week. So I get it. Yeah, so it's kind of up to you. Because if you are spending the time and your resources to work with somebody who you are screening in as, still a good fit for the program and it's working for them, then that's fine. But if you're finding that more and more they start out okay, but by the time you're getting to later sessions, they're declining to the point where they're not able to do it, then that's time. And it's not that it's time and effort wasted. I don't mean that at all. But if they really weren't a good fit for the program, then you have spent that time with somebody, or you haven't spent that time with somebody who maybe could have benefited more from the program. That's all. So it really depends on the person, and definitely working with family members and caregivers of anybody with dementia and Alzheimer's is going to be really helpful for them. But long-term effects for somebody with an Alzheimer's diagnosis, it's probably not going to help too long for them, right? Because it's a progressive disease and it's
terminal.
Yeah, unfortunately. Does that make sense?
Yeah.
Okay. Any other questions? Retention. Always a good disheartening discussion. I'm sure you've all had experience with clients dropping out. So emphasize with your trainees that having the right people in the program starts with getting good referrals. We just talked about this, making sure that people referring to you really understand what you can offer. And also so they're not talking to the Pearls or the potential clients and getting them all excited about a program that is not going to be a good fit for them. And having those conversations with the clients too. But once they do enroll, you want to encourage them to keep the client in the program at all costs. So putting sessions on hold, if the PST pieces are not relevant to that person at that time, we're really working on the behavioral activation, the pleasant activity scheduling or social activity or physical activity. Those are all important pieces too. And maybe them getting moving or doing something will help break them out of that funk and get them to a point where they are ready to engage in some of those PST problem solving steps. If people are, they are adults and they can say, I'm done with this program. This isn't what I thought it was going to be, or I don't like you, whatever it is, track those reasons, because at an org level, you may discover that there are some patterns that can be addressed. Maybe it's that there's one coach that is not resonating well with certain types of clients or all of their clients. That's a problem, and the organization needs to know that. But it could also just be that you will see or that they will see patterns that were in retrospect highlighted in the screening process, and then you can change the screening process to make it better, and making sure to help make sure that the people that do enroll are set up for success. Let's see. Oh, I have a question for all of you. Have you discussed reasons for that, for graduating early, like having that discussion with the trainees? Not yet? Okay. So ask Mark about that next week. Usually it's that they've made really great progress, and early graduation, I think, happens around 6 weeks. There are programs that have done as early as 4 weeks, and I don't think that's what we usually recommend. I think the minimum dose that we really want people to get is 6 sessions. But, sometimes people are just really into it and they really embrace it and do really well. And in that case, it might be okay to graduate and move on to the follow-up phone calls, because that's freeing up a coach to be able to see more of somebody else. But you can double check that with Mark next week. So measuring the outcomes. This is a core piece of the collaborative care model, making sure that we're tracking the progress from session to session. This is one of the core pieces of Pearls. We start with the PHQ-9. We want to see how they are before they get talking to us about how last week went and what they're going to work on this week. This is just so important. And let's see. I think Leslie has probably talked to you about this a lot, but just really encouraging trainees to make it a habit to do it right when they come into the session, get the client used to answering those 9 questions, as a lot of the coaches like to call it, and just getting into the habit. This is important for the organization, and may require the organization to set up ways to support this. But tracking this information it helps the client, it helps the coach see the progress of how they're doing, but it also helps the organization see the value add of the program to what they're offering their clients and helping them to go and get funding in future. You may have to talk through your trainees situations where the PHQ-9 might be an implementation barrier, ways to get around some of the trickier questions. We have some resources available on the PHLearn link, tips and tricks for doing the PHQ-9. And if the client is really vulnerable at a session, maybe they could skip it. Maybe they could just do the PHQ-2 that time, but trying to gauge where they are before starting the session is really important. We'll come back to that, don't worry. Staffing is a conversation that you definitely need to have. And if you're offering a training, you will get this question. Our org really wants to come to your training. Who should we send? Everybody. Maybe the answer might be everybody, but you definitely want to feel them out before they pay money to come to your training. It's great to let people know that existing agency staff can get trained. This is a huge appeal. They don't have to go out and hire somebody new to deliver this program. That can be a huge barrier, especially for smaller CBOs. our original research trained master's level social workers and nurses, but we found that we've gotten some great coaches from bachelor's level case managers, graduate interns, community health workers. Pearls is great for folks with limited mental health background. They do not have to be social workers to be successful in this. And actually, sometimes social workers have a hard time not trying to solve the problems because it is very patient driven. So, you know, we've had somebody who was a volunteer for an organization and they are retired from being a mail carrier for 30 years and they're great. Like they're a fantastic, they can connect with people and help them through the problem solving steps. So, you know, really emphasizing that can open Pearls up as an option for a lot of organizations. Oh, and you can definitely call the coach whatever is going to work for that organization or a term that's going to resonate with the populations that they're serving, the communities. We used to call all of the Pearls practitioners counselors, but in more recent years, we've heard from lots of people that they were uncomfortable with the term, especially if they were not trained counselors, and the service that they're offering is not necessarily counseling, right? It's a little bit different. So for some folks, they really hated it. So we've geared towards calling all of them Pearls coaches, but it's okay if they have a different term that is gonna feel better for what they're offering at their organization. So when you're talking about staffing, you know, they have to have somebody who's going to deliver the program. They have to have coaches in mind. You can let them know it can be full-time if they have a lot of people and they have a plan and that's what they want to do, or it can be part-time, or it can start part-time and move into full-time if there's enough demand and funding. There's no right or wrong way to staff the program. They are also so they have to have coaches and they have to have a clinical supervisor, and they cannot be the same person. That's the bare minimum. If they are going to be using social workers or folks who are in a case management role, they need to keep those roles separate, right? Ideally, they're seeing somebody else for case management and for Pearls. That's not always possible. If it's not possible, they need to separate their visits. Maybe 1 week they're doing one week they're doing the other, and being very clear with the trainees how they need to communicate that with the client. If they have to wear both hats, like today I'm wearing my Pearls hat and you're going to guide me through what you want to work on and blah, blah, blah. And this week, let's talk about, you know, getting you access to internet or, you know, whatever the issues might be. But the more you can separate, the more that the organization and the coaches can separate those roles, the better it is going to be and easier for the client. Other things that they may want to consider, having somebody to do outreach or marketing, doing the recruitment and referrals or screening referrals. They need to be tracking their data and evaluating that data. It's great if they can have a program manager. And if they are able to have a separate program manager or administrator who might be doing some or all of these other pieces, sometimes it's the coach doing some or all of these other pieces too. But definitely for a training, you would want to have the coach, anybody who's going to be a coach, and ideally the administrator or program manager, at least coming to the implementation pieces. It's great if they can come to all of it, even though they won't necessarily need those skills. Understanding what's involved is going to help them be a better program manager. If that program manager is also the clinical supervisor, definitely. I mean, that's super ideal. If they're planning to outsource their clinical supervision, or it's a provider at their organization who it's not a good use of their time, that's okay. Maybe they want to do the online training. maybe it's the program manager, the coaches going through the core elements of the program with them. So for training purposes, coaches, administrators for at least part of it. Does that make sense? Sorry, this is my world. I go through this all the time. So it's clear in my head, but not necessarily anybody else's. As you know, pearls can be offered in lots of different ways and places. We've seen so many different successful models. A lot of times we see like area agencies on aging organize at a local level. Like here in Seattle, our AAA funds and collects the data from several different community-based organizations. I know that's a setup in several other states too, cities and states. Sometimes the AAA offers it directly themselves, which ours actually in Seattle does. So they're sort of doing all of it. So there's not one right model, and helping them think through what's going to work best for them. If it's a AAA coming to you and they haven't recruited any community-based organizations yet in their area who would be delivering the program, like having that conversation with them, before they come to training. So maybe they work out, oh, okay, these are the types of organizations, or we have these organizations in mind. We want to get trained and we want them to come to the training. That's what we did in Texas 2 years ago. It was complicated, but there was a big AAA umbrella, and then all these different types of organizations, like faith-based and community centers and health clinics, all sorts. It was crazy, but there's just lots of different ways to set it up, and you as the trainer understanding who's coming to your training and the organizations that you are training in your area or in whatever area you're doing the training, it's going to help you tweak the elements of the training to meet their needs. If everybody's from one type of setting, then that makes it easy to customize the examples that you do or the conversations that you have. All right. Any questions about that?
Our AAA is like that. Here they farm out basically the monies they get through the OAA.
Yeah.
And so the grants go to different agencies to support that. And then they do an audit every year for 1 month that they pick out of the blue. But that's how they work it. And I think there are a lot of AAAs that do it that way.
Yeah, there are. And it can actually be a little bit more sustainable for some of those organizations to have the AAA managing some of the grant stuff, and they're performing the work and engaging with the communities. But there's not a right way to do it.
Yeah.
So just working with them to meet them where they are and try and help facilitate their needs locally. All right, I sort of talked about this a little bit already. If you're working with an organization that's big enough, make sure that they're giving presentations about pearls to other parts of their organizations to get those referrals, so that providers and different services at the organization know about pearls and know how to reach you or reach them and what it can offer. So great ways to talk about this. Examples you can give are staff meetings, in-service trainings, coalition meetings, health fairs or educational events, if it's like a huge organization. And we've seen a lot of different types of referral processes, but most commonly, it's a phone number that specifically is set up for referrals. Or I know Pat Kavanaugh down in Miami, Fort Lauderdale area, he created his own fax sheet that he gave out internally to their organization. and was he Veteran Services? Yeah, I think he was. And so to all of the providers, so they all had the specific questions that he wanted them to answer before making that referral. So giving examples of different ways to do this to the trainees is going to be helpful, getting them thinking about what might work best given their organization. And of course, a warm handoff, especially for providers to say, okay, I'm gonna hook you up to, such and such Pearls coach. They'll give you a call and follow up, and they might have some more questions for you. That's going to make it easier for whoever's doing the screening to get in the door with the older adults. And of course, having examples of testimonials and success stories is always great to add to any sort of written materials and share at presentations that they're giving. So any that you can share as examples are going to be helpful for the trainees. We are, as you probably know, we're working on getting the online training going by the end of November. So that will hopefully be the online training option that organizations can do. If you can offer an in-person training to get them started, that's ideal. Really, having the chance to interact face-to-face is the best possible training, that, in my opinion, based on now several years of managing all of these. It's just you build connections in a way that you're not able to online. But the online training that we are building is self-paced, so it's going to be very little face-to-face interaction of any sort. So we're hoping that the Pearls trainers like you all will still be offering local trainings. Once you're done with this, you can train people at your organization. When you have turnover, you can do local stuff. If there's other orgs in your area that we hear about, we may connect them to you and say, oh, well, we have a trainer in your area. Let me hook you up. And you can host a big training, you can host a little training, you can do whatever you want. And you can be paid for your time. They can pay you directly. We don't have to manage any of that. We prefer not to. But we love having lots of different options for people to get trained. So if you have a new organization that wants to start Pearls, if you can talk them into doing a training with you, with anybody at their org that would be involved, that's a great way to set them up for success. And then maybe later on, if they have turnover or they hire new people and it doesn't make sense to have you come out to them again, then maybe an online training for that new person would make sense. But it's really what works for you, what works for them. The toolkit is available online free for anybody. You can always direct people there for more information and our website, especially if you just sort of get a random call out of the blue, like, I heard about Pearls, tell me about it. I get those multiple times a week. They drive me crazy. It's like, thank you, I'm so glad. Please read our stuff, learn more about it. And then if you're interested in moving forward, we can have a call about what training would involve or whatever. Once you've trained folks, they are also welcome to join our technical assistance calls. You can do your own technical assistance calls if you wanted to host them, monthly or whatever works. You could just do it a few times after training, like we've done with our online trainings since the pandemic started. We have a group in Maryland that a lot of them do attend our monthly ones that we offer at UW. But they also host their own, and it's pretty great actually, because they can talk about local funding things or policy changes in Maryland. They can address things at a different level, especially since they all sort of got trained at the same time and started rolling with Pearls sort of together as a cohort. That was pretty great. All right. So if you do have administrators who join just parts of the training, what what we found is that they are really only caring about the core components of pearls and what makes it successful and what they need to make sure they are monitoring and following up on to stick to Pearl's fidelity. So what we've heard and what was identified in this qualitative study we did several years ago, the Pearl's Fidelity Study, creatively named, is that you got to do the PHQ-9 at each session. You got to do PST or behavioral activation at each session. Like we discussed, if PST is not hitting home that time, then definitely doing the behavioral activation, making it available to them in their home or community. A community location is important. Clinical supervision is a must. And hopefully by the time they've got to training, they have somebody in mind to be a clinical supervisor, or they have a plan in place of how they will recruit somebody to do that piece. That is required. That is an essential piece of the program. And it's really what makes it possible for anybody to be a Pearls coach, because we are assuming that they have a clinical supervisor who can advise on medications and step in if there's an emergency, or escalate to if there's a client who's having suicidal ideation. We don't want Lone Ranger Pearls coaches out there untethered and doing the good work, but without somebody to help support them. And they have to be trained providers. We want them trained by you or us, another trainer, but we really, those are the key pieces. Now, as far as adaptations, we've discussed, you can do a lot of different things with the program to make it meet the needs of the communities that they're serving. And if they have questions, they can come and talk to you. And if you're still not sure, you can come and talk to us, or they can talk to us. But, working through some of these different pieces is hard, but it's what they have to start thinking about, hopefully before they get to training, and definitely before they open up Pearls at their organization. Let's see.
This is Dina.
Yeah.
Can you just clarify and remind me what the specific qualifications / level of licensure is required for someone to be considered the clinical supervisor overseeing Pearls?
Yes, that is, there isn't a definitive answer. In the original study, it was a psychiatrist, but we have expanded that because reality. So psychiatrist, any sort of geriatrician, licensed clinical social worker, psychiatric nurse practitioner, geriatric nurse practitioner, anybody who has specific knowledge working with older adult populations, who is familiar with the medication dosages and could look at a client's medication list. And if, halfway through the program, they're not making the progress that you would have expected, look at those medications and say, that seems like kind of a low dose of whatever. Let's talk to their doctor and see if they might be willing to up the Prozac, or make suggestions. We're not diagnosing and we're not prescribing medications, of course, but hopefully the client will let them make connections to their PCP, and that might enable a conversation between the coach and the PCP, or the clinical supervisor and the PCP, to say, look, this is what we're doing. This is the progress that has been made, but we think that maybe with a change like this, more progress could be made. What do you think? So of course they have to have the participants' permission to do that, but that's, one of the forms that typically gets filled out when they enroll. So, and it's also, you can also let them know that the clinical supervision piece doesn't just have to be one person, right? So if you have somebody who can advise on the tough case part of it, but you just need you need somebody with the clinical piece for the medication. That's okay. You can have 2 or 3 people filling the role of clinical supervisor. It just can't be the Pearls coach is also the clinical supervisor. That's not okay. There needs to be somebody else to escalate to.
Just to clarify, so I have a geriatric social worker, I'm sorry, a geriatric psychologist and a nurse practitioner who specializes in working with geriatrics.
Okay.
If one of them were to, because they're both volunteers,
Mm-hmm.
decide not to volunteer anymore,
Mm-hmm.
would my program fall apart?
Well, I mean, you need to get somebody to replace that piece of it. But
Very hard. People are not. It's very hard.
yeah, I mean, it depends on the person and their expertise. So if that person, if one of the people leaves and the other one has those missing skills, then sure, you'd be fine. But if you don't have the medication piece, you need to find somebody who does and who can advise in a suicide protocol situation.
Right.
It's to protect you and to protect the client.
Right.
Yeah.
I'm just
You can talk more about it with Mark next week too. He's the expert on all things clinical supervision and suicide. Unfortunately, but he is. Any other questions? Okay, we've talked about adaptations a lot. It's just part of real world implementation, and it is not a threat to the validity of the program. So just reassuring, particularly administrators, that it's okay. And if they are worried about it, they can talk to their clinical supervisor, they can talk to you. We might be able to suggest, I mean, on the TA calls that we offer monthly, we try not to tell people what to do too much. I mean, we'll definitely tell you if it's like a hard no. And so it would be, you can tell them if you're helping them brainstorm through some of this, like what potential adaptations may be, you could bring it to a TA call and we might be able to highlight potential challenges to that. But other people may chime in and say, oh yeah, we've totally done that. And this has been really helpful, or this is how we did it. So Pearls is really flexible as long as you're sticking to the PST, the behavioral activation, the PHQ-9, meeting them where they are, and clinical supervision. A lot of the other stuff is pretty variable, or can be pretty fluid. Let's see, I think there's one more. Oh, yeah, I think we get to it a little further on, but reframing the way you talk about depression or the coach, those are pretty common ones. If you have visual or hearing limitations, we have different resources that you can, have the response cards made larger so that they can read along with you. You can always have them print out things to take with them. Let's see, we're going to talk about this a little bit later, so I'll come back to it. Try to move this along. Funding challenges and opportunities is hard. A lot of times you'll get a program that wants to adopt because they got some funding, and that's awesome. Definitely help them get on board and do it. But we also want them to think about sustained funding. What happened? A lot of the grant projects are 1 or 2 years, and it takes time to get rolling with Pearls. And so by the time they get to the 2-year mark, like that's when they're getting into the thick of it and they're like, yeah, this is awesome. But then they lose their funding and that's not great. So help them think about lots of different ways to fund their program. There are ways to tap into the Medicaid. In Washington State, we have a Medicaid waiver. You can talk to Leslie about it a little bit more. She's the expert on all the different funding pieces, but because Pearls is a self-management program, it's made it possible for some of the practitioners to tap into that funding. Here in Washington or in Seattle, we have local levies. Our Veterans and Human Services levy that has funded Pearls at our AAA and through that AAA to all those other community organizations that we have around here for many years now. They can have lots of different types of grants. There's some funding through Older Americans Act. They may have in-house discretionary funding from donations or pledges. They can use that. So there's lots of different opportunities. I know that the opportunities are expanding with the healthcare reform for specifically home health models. I don't know all the details about that. If you do, definitely talk it up with the trainees. If you're training primarily coaches, they may not be part of the funding discussions at their organization. Sort of depends on how big the org is. But if you have administrators, talking through some of this with them, connecting them to other organizations in your area who have found successful ways of funding their programs ongoing is helpful. And actually, that's a great suggestion anyway, is having peer support in your area. So maybe it's with your own organization, or maybe it's with other orgs that look like them. And if you don't have anybody else in your area, talk to us, because we know lots of different types of organizations all around the country that they might be willing to do like a little bit of mentoring. Data management, this is my favorite part. We don't require a specific way for organizations or coaches to track their data. There is Wellware, which is on a Salesforce platform. I believe it's $200 per user per year. That is run and managed by our friends here in Seattle at Sound Generations. That is available to anybody. It's got all the forms. It's got everything set up really nicely, but it's not required. PeerPlace is a really common one. I know that's what the AAA here in Seattle uses, and lots of different AAAs and particularly government organizations tend to use. You can use an Excel spreadsheet, or you could use paper. I don't think many people are using paper anymore, but definitely the worksheets are on paper. And so it's just a reality of the smaller organizations. They may not have the same resources. That's okay. We just want to make sure that they're tracking the PHQ-9 baseline and final questionnaire scores and information. Following up with satisfaction, both at the client and the provider levels. Organizations may have other outcome measures that they're tracking, self-efficacy, process measures. They may be tracking, it's a good idea to track referrals, enrollees, numbers of completers, numbers of dropouts. All of that is going to help them paint a stronger picture when it comes time to looking for those other funding opportunities and making the case for sustaining the program at their organization. All right, let me just stretch here. ReAIM is a model that was developed here at University of Washington. One of our colleagues, Basha Belza, and her colleagues. We love ReAIM because it comprehensively brings like a public health or population health lens to the evaluation work. And it helps expand our understanding of whether the program's working and how it's working. So reach is pretty clear. How do I reach the target population that we're trying to serve? Usually it's depressed older adults, but that could be more specific at an organization. Effectiveness. How do I know that my intervention is effective? You don't want to spend your time doing a program that's not effective. And so that's where Pearls as an evidence-based program is pretty attractive to a lot of organizations. A is for adoption. So how do I develop organizational support to deliver my intervention? So think of this as like the reach, but at the organization level. And an example of this is what we were discussing, like trying to make the PHQ-9 screening universal at their organization. Little systems in place to make Pearls as a whole successful with the other pieces of that organizational puzzle. The I is for implementation. How do I ensure the intervention is delivered properly? So sticking to the different things that we've talked about so far, fidelity, the core components of Pearls is going to be important to those administrators. And lastly, the M is for maintenance. How do I incorporate the intervention so it is delivered over the long term? So think sustainability for that one. So reach is really the representativeness of the population that goes through the program. So, you know, you want to know the number of people with depression that enroll in Pearls. And then to calculate that, you kind of need to know what the denominator is. So having that screening at a universal level at the organization is really going to help them understand how many people the agency serves that have depression. So how many have depression, and then how many are you able to reach? But if they're not doing universal screening and they don't have that data, you could track other things like rate of engagement. So how many were referred, how many got enrolled, and then how many completed. So this is all independent of whether the depression got better or not. You still want to have them collect that information so that they know, and they can make improvements when necessary. So effectiveness, this is the big one. And like I said, this is what appeals to organizations who are enrolling or who are adopting Pearls as a program. So there's 3 ways that we typically recommend they hone in on this, the changes in the PHQ-9. So most common is this smallest clinically meaningful change score. So this is a 5-point drop in the PHQ-9 from the first session to the last session. And this is probably the most common one that we see. The most people will meet this target. The greatest number of Pearls clients are going to meet this target where they drop at least 15 points from the start to the end in their PHQ-9. So clinical remission is if they get to a point where their PHQ-9 score is less than 5. That means they no longer meet the criteria for depression, for clinical depression. And then the response is 50% reduction pre versus post. So, you know, if they've cut their score in half, they've had a clinically significant response. So sometimes you need to look at these significant changes in different ways, because even if they've cut their score in half, they may still have clinical depression, right? You know, if they started high in the 20s and they cut it in half, they might still be at a 10 or, you know, a 12 even, and which is clinical depression. But you look at all the other factors too. So the improvement in their pleasant physical and social activities. Are they able to do more of the things that they want? They might still feel quite depressed, and that's okay. Ensuring your trainees that these are still significant changes and these are meaningful in the lives of the clients that they're reaching. The clients should be feeling quite a bit better. We never ever say that Pearls is going to cure the depression, right? That's not what we're trying to do. What we're trying to do is reduce the symptoms of depression, help them feel empowered to make these changes themselves. So reiterating this with the trainees is important, especially the folks who have had a social work background where they're used to going in and solving some problems for the client. It can be hard to let the client drive and maybe not make as much progress as they feel they could have made if they were the ones driving. And that's okay. That can be really hard for the coach. But what matters is that the client is feeling significantly better and that we're seeing that in the ways that we're tracking their progress. You want to make sure that the participant feels satisfied and the provider feels satisfied with how the program went for that person, tracking all of that. And then you can also take a look at their health services utilization. If that's something that that organization tracks, like, are they seeing a reduction in the number of hospitalizations or trips to the ER or other health services that are being utilized? That's something that we take a look at a lot with our different PEARLS research projects. Oh, sorry, I'm just seeing, okay, sorry. I just realized the chat was talking to me. Okay. So adoption's looking at how representative the program is within their organization. So this can be looked at a couple different ways. Like if we're talking about the AAA situation, they might be looking at how many different CBOs in their city or their region have adopted PEARLS. If it's a smaller group, they might be looking at how many people are enrolling in the program and how many different communities they're able to reach, or different types of people they're able to reach. How many you know what I'm trying to say? Like, are you being as effective at reaching everybody that your organization serves? Or are you only seeing white women, right? Like, and so taking a look at that, helping them understand ways that they can assess that and make changes to their outreach or implementation so that they're meeting people where they are. And if you have different organizations in your region, or they do, taking a look at how long they're staying or they're offering PEARLS. If you trained them a year ago, how many are still offering the program? So the better we can learn why it is that they stopped offering. Was it just funding, or was it something about the program that they didn't like? That can help you either re-engage them as trainers in the area, or support the region in being able to offer PEARLS. But it can also help you as you're working with organizations who are interested in adopting, to help make sure it's a good fit. Does that make sense? Sorry, I'm sort of all over the place there. All right. Implementation fidelity is looking at how closely the program meets the evidence-based practice model. So which of these core components are being done, and are there any that need modification? This is where you might work more closely with the administrators to say, this is what you have to do. Okay, this is what you are doing. And I think you could improve here. They also want to know how much they can bend the model. And like we've discussed, they can bend it quite a bit as long as they have those core components in place. And maintenance is, like I said, it's the sustainability of the program over time. So not just significant improvement in the participants, but looking at their over time, like, are they increasing the number of participants that they're able to offer the program to? Maybe that's not, maybe capacity is a problem for them, but are they maintaining the same numbers of clients, enrolling the same number, graduating the same number, having the same success in the scores over time? These are all different ways to make sure that PEARLS is still being effective for those organizations. All right, so we are down to the wire because there's a lot to talk about, and I'm so tired of talking. I can't wait to hear you talk and teach back to me very shortly. But we're just going to quickly go through what, if you're doing an in-person training or even online with Zoom, what that might look like for each of you. Now, I recognize that maybe you're just here because you want to train new students who come in, or new staff, and you don't ever want to teach anybody else ever. But still good things to think about and help whoever you're training to think about too. So using the different materials, you have access to all of these. What's it going to look like using these materials and resources and working with potential new adopters? So, like I said, main audience is probably going to be the coach. You might also have a leader, an administrator, program manager. You may also end up with some case managers who aren't necessarily Pearls coaches. And actually, that's kind of awesome when they can come, because these are more tools that they can have in their tool belt. But this is going to help the case managers like really understand how the program could help their clients and work better with the folks who are going to be Pearls coaches, so that they can work a little bit more collaboratively. So I definitely love to see case managers at the trainings. And the feedback we've gotten is that they find it really helpful, even though they're not necessarily going to be the Pearls coaches, they still find it really helpful. If it's an organization that has a data coordinator, it's helpful. They wouldn't need to go to the skill stuff, but they are totally going to want to understand all the different pieces of screening and implementation, so that they can start thinking about what they already capture at their organization and what they're going to want to add in to capture. So, all right. Lots of different, like I said, there's lots of different instructional strategies that are going to be used, because people will respond differently, and they may be better at learning by reading. And so the toolkit's going to be really helpful for them, or they really might just want to listen to you talk to them. Or it's the demonstrations and observations, the role playing, going through the scenarios and thinking about applying those skills to real life situations that are really going to resonate with them. So offering different strategies is going to be important. For preparation, I would definitely ask your trainees to review the toolkit. What we've done since the online trainings during the pandemic, we've had people complete the online training pieces, but that's about to change. So I think my recommendation still is going to be have them review the toolkit. If you come up with a better idea, let me know, and we might be able to work something out together to help them come to the training, not as blank slates, but just having an idea of what they're getting into. And then during the training, you're going to go through all of the stuff in lots of different ways, and they're going to be overwhelmed, but then you're going to have follow-up with them. They're going to evaluate you and your training. They're going to give you feedback. You may do technical assistance calls with them. You may want to do a couple, if an organization says, we'd love like one follow-up meeting just to like ask some last questions or go through it a little bit more on this one section or whatever, you could do that. But they are also going to have opportunities through their supervision and through doing the program and joining either your TA calls or my TA calls or both TA calls, or working with each other and their peer group to process and synthesize the information a little bit more. This is just another way to look at it. These methods are organized on a continuum, and this is to build and reinforce the knowledge, skills, and the other learning objectives that we've discussed. So have them take a look through it. The toolkit, you can make specific requests if you want, but it's really up to the group that you're training what you specifically want them to come ready to talk about or absorb from you. So we have all of these materials available online that you are welcome to use: agendas and objectives, toolkits. The toolkit's always there and updated, forms, the handouts, evaluation forms that they'll use. You'll have notes from this, our slides, our recordings, the manual. We don't have flip charts for you, but you can get flip charts if you want to do flip charts. And of course, the PHLearnLink website is there, and you should be able to access and use the videos that you've seen from that. So if you're training by yourself, which I don't recommend because it's nice to have somebody to banter with, but if you don't, and you are by yourself, you can use those videos from the prior training that we have with examples of, first session or middle session or going through the PHQ-9. You can use any of those resources for your own trainings. Definitely make use of those.
You have flip charts that we could get, for training?
I don't, because they're just Post-its and we just scribble on them and then we recycle them.
Okay,
All right, it's nothing formal. It's literally just a giant Post-it that we write on with markers, because we draw the stool and we, work through different topics in the parking lot and all of that. So, yep, they will continue to train. Clinical supervision, you can remind them that that's a good time to hone some of those skills with their clinical supervisor when appropriate, especially tricky situations with, more complex clients that they might have. TA conference calls, all that, they can email us. And you can make yourself available to your trainees however you want afterwards. That's up to you. I would love it if you would send me your roster so that we have a sense of who the new programs are and who's staffing those, so that I can invite them to our monthly TA calls. So please do that. Otherwise, I have no idea who gets trained. And then all of a sudden there's people asking to be on our TA calls. And they're like, oh yeah, we got trained in Maryland. I was like, oh, that's cool. What? Totally fine. But, it just helps us so that when we get requests for referrals, that I know that they exist and I can connect people who are trying to get their dad help or their mom help or whatever. So, all right. I talked about a lot of stuff today. So before we do teach back, any questions about the materials that I rushed through for an hour and 22 minutes?
you've done good.
Thanks.
A lot of work.
I'm enthusiastic about implementation and training, so I have a lot to say. A lot, sorry.
Don't be sorry.
Did you have a question, Andrea?
No, I was just telling you to be kinder to yourself.
Oh, thanks. I'm not very good at that. Leslie and I are always trying to pull the pearls stuff on ourselves. She's like, wait, hold on. Let's 7 steps. Okay. I'm going to jump forward to the teach back first, and then we'll come back to the frequently asked questions if we have time, because we sort of talked about them already. So who would like to describe 3 ways that an agency can measure Pearl's program effectiveness using the PHQ-9?
That was on the effectiveness slide, right? Like embedded into REAIM?
It probably was.
The one where it talked about like this smallest clinical meaning.
Sure does. Thanks for volunteering, Andrea.
Yeah, I can do either one of them. I was just making sure I was looking at the right thing.
Yeah.
So if somebody has a strong preference for one or the other, I don't have one.
Or you can just discuss one of the ways if you want to pass the torch. That's fine.
Oh, yeah, I can talk about all 3 or do the second one. I don't really have a preference.
Yeah, I can do either. I just got a text from my daughter that she needs me to pick her up, so I can do either, but I probably.
Dina, do you want to do the first one so that you can?
Okay, Dina,
want to do?
You just start talking, Dina, and then
Okay.
You can pass the torch and go get your daughter.
Okay,
Definitely.
I'll do the describe the ways that you can measure effectiveness using the PHQ-9.
Great.
So the PHQ-9 which is used to kind of monitor effectiveness with the client in each session in terms of monitoring their depression symptoms, can also be used as a way to kind of review overall effectiveness of the program for the clients that we're working with. And 3 ways that you can use that is by documenting the smallest clinically meaningful change score seen with the patient or with the client as they're completing their work with Pearls. And that is representative of a 5-point drop, I think, from their initial score to their final score. Another way is if a client reaches just remission in terms of their PHQ-9 score, and that would be a score less than 5. So if they started out, at a 7 or 8 and they get to a 5 and have reached remission, that's another way that you can document that that Pearls has been effective for them. And the third way, let's see if I can read my chicken scratch. A 50% reduction in their score pre versus post. So that would be a way that someone that had maybe didn't reach remission in terms of getting less than 5, but they started out with a really high number and were able to reduce that by at least 50%.
Mhm. Yeah,
Does
a
that cover
clinically
it?
significant response. Perfect.
Yes.
Yes, great. Anything anybody wants to add or have questions or anything? Dina, you can pop off whenever you need to.
Okay, thanks. Sorry that was kind of rushed.
Nope, we're rushing now because I took too long. Thanks.
We also need to track their present physical and social. We can also do that in remission, yes?
Mm-hmm. Yep. All right. Do we want to pass the torch along as we describe what REAIM is and how it applies to Pearls?
Go
Yes,
slower.
Can you go back up to slide 22 for me, Caitlin,
I
if you don't
can.
mind? Thank you. Sorry, my voice, our weather, hot and cold over the last week down here has led my allergies to being
Oh, I hear
out of
you.
control.
I'm sorry.
Our weather can't decide what it's doing, so
Yeah.
I get
I
this.
understand.
Okay, so REAIM. REAIM is an acronym that was developed out of Washington, and it kind of brings in that public health lens to look at how, if Pearls is working and how Pearls is working in the lives of our participants. It also, so the first reach here, how do I reach my targeted population? Am I reaching my targeted population? So some things that can help here are doing like universal screening at your organization for depression, giving everyone who phones in or comes in a PHQ-2, and then with education for your staff, knowing if they would be maybe a good referral to Pearls, to make sure we're reaching that targeted population of our older adults with depression. The E is effectiveness. Evidence-based practices are really attractive to organizations and particularly funders, especially if you're going after grant funding or public funds, like my organizations work with public funding. So we need to use evidence-based practices. So we need to know this intervention is effective, and the evidence base behind Pearls helps us demonstrate that. And the A is adoption. So how do I develop the organization to help support the delivery of Pearls in this particular case? So that goes back to making sure our staff kind of across the agency are educated in what the program is and have some either basic level of understanding of Pearls or even go through the full training course with us, depending on kind of the need we have in our organization for each person to do that. And this is another place universal screening can also be really helpful, making sure that we have clients that we can use Pearls with. Universal screening can help us with that. Next, our I, implementation. How do I ensure the intervention is being delivered properly? So making sure we're sticking to our core components. This is really talking about fidelity. So making sure you have folks that are trained and that you have some kind of fidelity oversight and clinical supervision built in. Clinical supervision is required, but that folks understand how to do fidelity monitoring, that your Pearls coaches know what fidelity to the model looks like and are willing to take the steps necessary to maintain fidelity to the model. And then lastly, maintenance. Here we're really talking about sustainability. What things are you going to put into place that maybe after your short-term grant has ended, you be able to maintain implementing Pearls? Are you able to find other grants or other sources of funding in order to continue to sustain your program in the longer term? And that's what REAIM is looking at. And we're going to go into each of these pieces in a little more detail.
Oh, that was good. I'm just going to clip that out and just use that in the future. That was great.
Thank you.
Any comments, questions for Andrea?
I think you did really well, Andrea. I understood each piece from how you described it. So I think it was taught well.
Thank you, Allison.
All right, well, thank you. Excellent teach backs. So we are at 1:30 as time. You are welcome to hop off if you want, or if, let's see. Oh, just reminder for next time, you're going to talk with Mark about suicide and self-harm, clinical supervision, and then teaching trainees how to do the final Pearl session. Because as you know, it looks a little bit different than the previous sessions. So we've got some homework online. I'll have the recording and the slides updated later this afternoon. Toolkit pages 49 and then 101 to 105 is what Leslie had on there. If you want to stay on for a couple minutes and talk about the FAQs from trainings, I'm happy to do that, or you can take off. I know everybody has busy schedules, so whatever you need. But thank you all very much.
Thank you, Caitlin. See you later. I have another meeting to run to. It's an
That's fine.
overlapping meeting day. All right,
Yeah,
thanks.
I
Till
understand.
next week.
That's fine.
Thanks, Caitlin. I have a
Yeah.
note for a wellness visit I need to finish. I did right before this, before I
Absolutely.
leave.
Go for it.
So,
Yep.
it was good to see you.
Yeah, you too. Take care.
That leaves you and me, Caitlin.
All right, well, then that is fine. So I just have two things to touch on that tend to come up quite a lot in trainings. So the first one is, can anyone be a Pearls coach? And so thinking about when you're talking to an organization or a person about a training that you're going to be offering, if they have this question, like, how would you describe this? What would you say if somebody asked you, can anyone be a Pearls coach?
I would say it depends on their personality more than anything anymore. Are they able to not find the answers for people, but help them to find their own answers? I liked your explanation of the mailman
Mhm,
who made a wonderful coach for people,
mhm,
whereas there could be social workers who can't resist telling people how to fix the scenario, or can't resist telling them what they should change.
mhm.
I have one client that she's a hoarder, not, she's perfectly happy. I'm dying to tell her, clean this mess up, but that's not my place.
Not in this role, right?
Not in this role, right? And so I think sharing those, I'm one of those, I teach by examples. I think sharing those kinds of examples. Who is it that you're thinking about hiring? What skills do they have?
Mhm,
How do they relate to people? I think those are the important things, rather than having a master's in social work
right.
or a PhD, those kinds of things.
Yeah. And you just mentioned something that I want to reiterate. If they're thinking about hiring somebody, definitely looking at other skills that they have too, but they don't necessarily have to hire somebody else. And that's sort of, I think a lot of times when we get this question, that's what the organization is kind of asking, like, do I already have people who could do this at my organization? And the answer is probably yes. They may not have social workers, and they may be wondering if they have to have social workers to deliver the program. And the answer is no, we don't have minimum criteria. It's their skills and experience and getting trained. And the reason that this is that this is the way we have it set up now, and that this works, is because we assume that everyone is going to have a clinical supervisor, and that clinical piece is, just reiterating that that is a requirement for them, because it's providing the additional support to somebody who is a social worker, but also somebody who may be a community health worker or a volunteer, a retired volunteer, so that they all have access to the same support, especially for tricky clients or clients who are not making the progress that at the rate that we would have thought,
Yeah.
or like to see. Okay, and then we did talk, I did talk about this quite a bit today. But if they come to you either before training and they say, oh, well, is Pearls available in other languages? Or if they get to the end of training and they say, gosh, I don't really know if this is going to work for our org. I don't think this is culturally appropriate for the people that we serve at our organization. What are some ideas that you would have to answer questions like that?
If I'm correct, you have the information also in Spanish. And I think
A lot of it, yeah.
populations was one of the African countries.
Mhm. We have Somali. We have,
Mali, that's-
so yeah,
So-
it's important to understand that we don't have the entire program translated into anything but English. But a lot of the forms have been translated. We have Spanish, some in Korean, Somali, I think some in Russian, and maybe some in Chinese.
Wow.
But it may be some of the forms that clients might see, but it not necessarily all, like the toolkit is not in other languages, and some of the forms that just the provider or the coach would be accessing, those wouldn't necessarily be translated. So just being clear about that. But they're welcome to translate any of the forms or materials, definitely. And we always love it if they can share it with us so that we can share with other organizations.
Right. And, another thing to say is, for me, at least my experiences working with the 60+ population, you never use the word depression. They go running the other direction. You're supposed to grin and bear it, at that population. And so finding ways to, I don't want to say work around, but use word appropriate titles, word appropriate statements for the population we work with. I think that also is important. So being able to communicate that would be part of what I would answer.
Yeah, and that's absolutely true. I mean, that falls into the cultural appropriateness. It's not just people from a different background or a different place in the world. It's also generations are different cultures in a way. So yeah, using words that are meaningful and helpful for conveying the ideas of the program and helping them bridge the gaps between what Pearls is and how you're able to build that trust and rapport with the client. Definitely totally allowed and encouraged. Some populations will engage better with a coach who is similar to them in a way that they can connect to. So as an example, some of the funding locally for Pearls was specifically for doing Pearls with veterans. And we found that it was essential to have a coach who is a veteran, not necessarily an older white man, but somebody who has experience in the military in one of the branches and understands that culture and shared experiences there was essential for connecting with the veterans and helping untangle some of that, just as an example. But it's not always possible to have Pearls coaches on staff who are going to meet all of the different clients where they are and be able to make those connections. So when that's not possible, it's totally fine to have interpreters. It's great if there can be coaches that are bilingual, bicultural, but like I said, that's not always possible. So using the terms, using the words, the phrases that are resonating with the different populations is important, and building bridges to to bridge those gaps whenever possible. There's always opportunity for cultural humility and additional trainings for folks if they have a community that their organization really is striving to serve, and they don't at the time have coaches who are the best possible fit until they're able to find somebody who can serve in that role and be that fit. Getting additional training to help reach those clients and help them feel safe and understood and open those doors a little bit more for them. That makes sense?
Yeah.
Okay. Yeah, you did great. Those are just two of the common ones. There's lots of FAQs, and there's a list on the PHLearnLink website, and also with our other Pearls, just general Pearls FAQs that are available on our Google Share Drive. So all of those will be available to all of you after becoming trainers. So,
Yeah, I'm nervous about that test.
oh, well, it's all stuff
Oh, you think? Thank you.
what you've been doing Pearls a while now, so you know it, and it's just learning about how to teach others to do it. That's the tricky part. But
To me, that would be the easy part. The test, it's like last week, one of the 10 questions was about working with people with, Alzheimer's specifically.
mhm,
I answered it wrong because, evidence-based programs out there are now saying that, earlier, not earlier onset, but earlier when people are discovering the dementias sooner. And
mhm.
so you can work with folks some or with their families. So I thought of it, yes, we can work with them.
Yeah, and
Right.
it's, as we discussed, it's pretty situational. As a blanket answer, typically it's not going to be possible with people with it. And that's why you do the cognitive impairment assessment, gauging where they are, because it is individual. And that's why, we don't just blanket say nobody with bipolar disorder can do Pearls, right? If it's well controlled, if it's managed and they're doing well, sure. If they are an alcoholic, but they're getting treatment and they're not actively, using, sure, they can do it. But if they're not going to be able to follow the different steps required on the worksheet and follow along with you and follow through to make your appointments, to do their homework, then it's not doing them any good. It's not doing them any favors, and it's using up your time, and you are a valuable resource as a Pearls coach. So, yep. All right, well, I'm going to have to jump off and get on more Pearls meetings, but it was nice to see you. And
I have one quick question.
oh yeah.
You were going to put out a request to find out if